A 42-year-old woman, an elderly man with a history of angina, and a pregnant patient in her first trimester. 3 distinct physiological profiles, all presenting with the exact same lab value, a TSH of 14.5. An elevated thyroid-stimulating hormone is one of the most frequent lab flags in primary care. The standard medical school reflex is immediate. Write a prescription for levothyroxine to push that number back into the normal range. A high TSH is a clinical signal, but it is rarely a complete diagnosis. When treatment ignores the specific physiological context of the patient, clinicians often find themselves chasing fluctuating numbers while the patient's symptoms persist. To navigate these complexities properly, we have to rely on the clinical framework provided by the American Thyroid Association. We are going to deconstruct the hypothyroid phenotype by evaluating 5 primary care challenges. Managing this condition involves a delicate balance of pharmacokinetic discipline, identifying systemic symptoms that masquerade as distinct diseases, and navigating the narrow treatment windows of high-risk populations. Mastering hypothyroidism requires the active management of a network of compounding, patient-specific variables. Consider our first scenario, a 42-year-old woman presenting with classic signs of metabolic slowdown. She reports several months of fatigue, a 4-kilogram weight gain, and severe cold intolerance. Her clinical readout shows TSH elevated at 14.5 milli-international units per liter and free T4 below the reference range at 8.0 picomoles per liter. This specific combination characterizes overt primary hypothyroidism, distinguishing it from subclinical or secondary presentations. The mandatory next diagnostic action is ordering a panel for thyroid peroxidase or TPO antibodies to establish Hashimoto's thyroiditis as the underlying autoimmune etiology. Beyond the core labs, her physical examination reveals localized neurological complaints. She describes nocturnal hand tingling and demonstrates a positive Phelan sign at the wrist. The immediate instinct might be to refer her for nerve conduction studies or surgical decompression. However, carpal tunnel syndrome is a documented systemic association of hypothyroidism. The endocrine deficit causes mucopolysaccharide deposition and soft tissue swelling that mechanically traps the median nerve. Returning to her chart, there is a final anomaly to address, a heavily elevated total cholesterol reading of 6.9 millimoles per liter. Do not immediately initiate a high-intensity statin or fibrate to correct this lipid profile. The physiological sequencing dictates that this secondary hypercholesterolemia is driven by the endocrine deficit. The lipid profile frequently resolves on its own once the patient returns to a euthyroid state. Primary care physicians must immediately recognize downstream manifestations like neuropathy and dyslipidemia as direct systemic signs of the primary disease. The thyroid must be normalized before any distinct mechanical or pharmacological interventions begin. Once the diagnosis is clear, the mechanical reality of treatment begins. Levothyroxine's efficacy is dictated entirely by strict administration protocols. The medication is highly vulnerable in the gut environment. It carries a narrow therapeutic index and suffers from highly erratic absorption. This graph illustrates the baseline administration rule. To achieve this optimal absorption curve, the medication must be taken on an empty stomach at a consistent time. Specific everyday dietary habits destroy this absorption profile. Coffee, calcium supplements, and iron preparations act as direct pharmacological blockers. Clinicians must then follow a critical timeline for monitoring. You must avoid the common error of rechecking TSH levels at the 2 to 3 week mark. Due to the prolonged half-life of T4, the hypothalamic pituitary thyroid axis requires approximately 6 to 8 weeks to reach a steady state. Premature dose adjustments based on early labs completely bypass this half-life. This guarantees a clinical pendulum effect, trapping the patient in perpetual over- and under-treatment. Treating hypothyroidism requires rigid pharmacokinetic discipline. Respecting the drug's half-life and absorption parameters is just as critical as selecting the correct dosage. Applying these standard treatment protocols uniformly is incredibly dangerous when managing complex patient phenotypes, particularly the elderly cardiac patient. This presents a specific clinical dilemma. Should a practitioner actively treat a highly elevated TSH, above 10, in a patient presenting with active cardiac symptoms? Treatment is necessary, but risk is severe. This tachometer model shows sudden metabolic acceleration from a standard levothyroxine dose, dramatically increases myocardial oxygen demand. The ATA guideline modification initiates a lower microdose, titrating cautiously to prevent an acute cardiac event. We enforce another strict set of rules with our final critical phenotype, the pregnant patient presenting with subclinical hypothyroidism. While treating subclinical numbers in the general population is often a clinical gray area requiring observation, pregnancy alters the risk profile entirely. This decision matrix maps out the hard ATA rule. If the decision to treat subclinical numbers is otherwise ambiguous, current pregnancy or active planning for pregnancy is a definitive trigger for immediate intervention. Fetal neurodevelopment relies entirely on maternal thyroxine supplies during the highly critical first trimester, creating an absolute and immediate developmental urgency. Physiological modifiers, whether advanced age, cardiac vulnerability, or fetal development, must override standard dosing algorithms. Clinicians have to aggressively adjust their treatment thresholds. Taking all these variables together allows us to build a unified, dynamic clinical engine for managing the hypothyroid patient. Confirm the autoimmune etiology with TPO antibodies. Resolve the thyroid before treating the cholesterol. Enforce fasting administration and respect the 6 to 8 week steady-state delay. Product labeling, specific target ranges, and jurisdictional protocols vary. These principles must always be integrated with your local guidelines. Clinicians achieve stability for the patient by integrating these lab values into the broader, interconnected context of human physiology.